Good morning, Jillian. So I guess everybody's looking at my slide and then on the side, the next couple of slides. Is that correct?
This is Jill. Can you hear me now?
Yes, I can.
Yeah, so we can see the next two slides, excuse me, on the left-hand side.
How do I fix that?
Um,
I can do,
down on the bottom of your slide,
yeah, right on this one.
it looks like a goblet. Yeah, yep. Click on that and see if that works.
Get out of here first. Okay. It's doing the same thing.
So just a moment ago, when you were sharing your screen,
Yeah,
you clicked on something and it showed only your title slide.
really?
But I'm not sure what you clicked on. What if you click on from beginning? Does that do the same thing?
Yeah, I don't know. It's weird. Oh, it's stuck on the second slide. If I say, there we go. Things are just kind of slow here. Let me see. Anyway, it don't matter in some respects.
I think that we can see it just fine.
Let me try to make it just a little bit bigger then. Better.
Yeah, we can see it a little bit better.
Well, it's 8:01, so I guess I can just start.
Yeah. Feel free to get started. Thank you so much for being here.
All righty. Well, good morning, everybody. My name is Marty Weiss. I'm an infectious disease pediatrician and the chief medical officer for the Children's Hospital. Dr. Rich Brandt, my partner in crime, cannot be here today. He's attending on the ward. He's a pediatric hospitalist, and he's the chief quality officer for Children's Hospital. So one of the benefits that both of us have is that we get to see and hear a lot of pretty much every one of the patient safety incidents that occurs in Children's Hospital. Myself, as an infectious disease doctor, I get to work in the NICU, the newborn nursery, the pediatric ward, the pediatric ICU, so I go everywhere and see everything. And then we all every day get to, every morning, the entire hospital, Ruby, sends out the patient safety events for the past 24 hours. So we could see them from throughout the hospital. This is a big topic. So the learning objectives for this morning is really just to understand the history and foundational concepts of patient safety science. And the second one is that we're going to talk about the just culture and be able to apply just culture principles in different aspects of your life, not just here at work. And then finally, be able to evaluate a patient safety event. And so we're going to, I was told, I guess, that really this should be interactive. This is, I don't think anybody likes doing Zoom lectures. Maybe some people do, but I don't. And I wish we were in one of those big auditoriums by the pylons, and so I could see you all and so on. But we're going to try to make this work. So you all know this. You all know primum non nocere. You all went through the white coat ceremony. You all talked about this, and really the first job of the physician is not to harm our patients, right? So that's kind of where it starts. So the patient safety movement, if you will, started about 2,500 years ago, when it was recognized that we as physicians can cause harm, right? And so that's how old this is. Now, it really started in about 1956, and it was really interesting. If you just go to iatrogenic disease or something and just go to Google it or Google Scholar or whatever, you're going to see a whole host of articles pop up from 1956. One of them is 1,000 deaths from anesthesia, right? And so like, whoa. And so what that was, there had been an article 4 years earlier where they looked at 400 deaths from anesthesia, I think from one health system. And then they asked people from around the world, around the country, to send them anonymous information. You think 1,000 deaths from anesthesia, wow. So it was, and you think about it, right? And so antibiotics weren't available until about 1950s. Chemotherapeutic agents were not available until about the same time, right after the Second World War. And so think about chemotherapy, right? So there's these cancers, and then there are these agents which we know that can stop rapidly dividing cells, and therefore helping with the cancer. And then, oh my gosh, it stops the bone marrow also. So then you have all these people who had cancer and had a bad, horrible disease already, and now instead of dying from the cancer, they're dying from bleeds or overwhelming infection or something like that. And so there's a whole bunch of different things that we in medicine have done to help patients, but ended up harming them. Before, I think it was late 1980s, Helicobacter pylori was discovered as the cause of gastric ulcers, was the most common cause of gastric cancer because of the chronic infection. So when I was a medical student in the 80s, oh my gosh, in surgery, we would go to the OR, and a whole bunch of our cases were gastrectomy and then, vagotomy and antrectomy, or pyloroplasty and vagotomy, and something like that, to try to help prevent or ameliorate the gastric ulcers. 10 years later, there were no such surgeries because we found out that it was an infectious agent and we could treat it. And so we were harming a whole bunch of people with what at the time was state of the art, but we were still harming people. Let's see if I'm doing this there. Darn it. Okay, we'll do it this way. Next, in 1994, Lucian Leape published this Error in Medicine article. And really, this was, I would say, is regarded as the start of the patient safety movement, if you will, because in here, not only did he point out that there are errors in medicine that harm people, but he was the first person who presented a systematic way of looking at medical error so that it can be examined, each event examined, categorized, and then a plan for amelioration of that. 1999, so I was actually I was working here at WVU, and I remember I was the residency program director for pediatrics, and this came out, and it said the famous "To Err is Human," and it said that 99,000 deaths per year occur in American hospitals due to medical errors. And I'm like, this is BS. You know, the reason that people are in the hospital is because they have really serious life-threatening illnesses, and they're dying from these life-threatening illnesses because of the illness, and we're trying to help. And if some of them die, I can't see how that could, well, now I think that is probably downplayed by a factor of like at least 5 and maybe 10. So being able to see all the errors that occur here in my hospital, it's really kind of is frightening. James Reason was a psychologist, I believe, and he looked at errors that led to harm in a whole bunch of different industries, aviation industry, automobiles, and so on and so forth. And he was the person who first really said that, listen, we need to stop thinking about error as an individual error that somebody did and start looking at as a system. And so even if there was an error that a person made, why were there not other systems there to prevent that from happening? And so he's the one who first coined or popularized or came up with the Swiss cheese approach. Now, This slide I got, or this image I got from the AHRQ site, which talks about patient safety. I think this is the dumbest Swiss cheese picture I've ever seen, because what you want is to slice the Swiss cheese and take every one of the slices and turn it 90 degrees so that it's not going through the same hole. So anyway, the whole idea of the Swiss cheese is that if you can add a number of layers on that prevent any one step from harming the patient, it's unlikely the patient's going to be harmed. If you make a system with this kind of Swiss cheese, obviously the patient's still going to get harmed. Okay, so part of the reason that we're talking about this is because we have to. And you need to know this stuff for your boards, quite frankly. So I was giving this talk yesterday for the first time, practicing it with a fourth-year medical student. And I said, hey, well, how did it go? And blah, blah, blah. And did you have, how much of this was on your boards that you just took for step 2? She goes, oh my gosh, more than you think. So it turns out that that something like 7 to 8% of the US MLEs have safety, quality, and systems. 7 to 8%. So this is stuff you have to know, right? And so Dr. Williams asked us to give this talk. So so this is from the AHRQ primer on patient safety. Here are the different kinds of error, and there might be more, depending if you're a lumper or splitter. So transitions of care, handoffs. We see this all the time. Patients coming from either post-op from the OR, they go to the step down. They go to the post anesthesia unit, and from there they come to the pediatric ward, or they'll go from the OR to the peds ICU. And the handoffs are terrible. From the daytime to the nighttime, the handoffs. There's medication errors, which are the most common source of patient safety events in both the Ruby and in Children's Hospital. Procedural errors, healthcare associated infections. When I got to so I was at WVU in the 90s. I left in the mid-zeros. I came back 4 years ago. I came back January of 18. In December of 17, there were 5 central line infections in the neonatal ICU. 5 in the neonatal ICU in 1 month. We joined this organization called for Solutions for Patient Safety, which is the Children's Hospital Association thing. And at one point we were up to like 500 days without a single central line associated infection. And it was all because we instituted these bundles that the best children's hospitals had been using. Documentation of errors, patient identification errors, diagnostic errors, monitoring errors, device-related errors. We're going to talk about specific cases about these at the end, and that's going to be the audience participation part of the talk. So when you think about, okay, here's the errors and how do we reduce errors, there's like four things, right? So human factors, engineering. In other words, if you say to somebody, hey, you need to do this in order to be safe, there ought to be some kind of cues or reminders for us to do that, right? And so, whether it's, there's this like famous one about in the MRI, make sure you don't bring anything magnetic into the MRI suite. And somebody walked in with their white coat on and they had a metallic object and it flew off and it went to the magnet, and thankfully nobody was injured. So now, before you enter the MRI suite, there are big signs and there might be other different things to remind people not to do that. So first of all, it's just situational awareness, but also visual cues and then forcing functions. We can use our EPIC electronic health record to force us to not forget things. Error analysis tools. So what we do in the big hospital and children's hospital, that people can go either to the hospital website or on EPIC and put in a patient safety report. And it's just like, hey, this happened. I was giving this patient this medication, and I went in there and it wasn't there. And so I called pharmacy and it didn't get there for 4 hours. And so the patient missed a dose of their medication, which needed to be on a certain time. So then we can get that and look at like, well, why did that happen? And where was it from? And so on. Safety behavior and culture at the individual level, right? So this is just everybody having personal responsibility. And then the other part that goes along with that is that, medicine does not happen by individuals. It happens within a team. When I came here 4 years ago, I just retired from the Army. My previous job was safety and quality at Walter Reed. And there was kind of a culture of safety developing there. When I came here and I interviewed for the chief medical officer job, and I was like, oh, hey, is there a culture of safety here? And even the chief safety officer for the entire hospital just kind of had to look at me like, no, we do not have a culture of safety. We're trying to develop one. We're trying to build one. And that's where you guys come in, right? So you can't believe how important you are, even when you come onto the boards as students about promoting safety. So not just for medical students, but for residents, right? So the key principles of patient safety. So this is, like for the pediatric residency review committee, this is what the program directors look at. We have to teach this to ours. So this is really important. And again, this is just for medical students, not just for residents, but it's supposed to be for everyone. But let me tell you, if we don't teach it to the students and residents, it's never going to take. For the next like 6 or 8, whatever slides, I'm going to talk about the just culture. Anybody using your little things, how many people are familiar with the just culture? Put up like a thumbs up or a raised hand or something like that. So I can, actually, I only can see 5 of y'all, so I can't even do that. Never mind, forget it. I'll pretend like you haven't heard of it. Okay. So first of all, there's different kinds of justice. And again, lumper splitter, right? So there's, if you go to the Just Culture website, it'll talk about all this. So it's one of them is distributive justice. So I don't know if you all saw the commercial with Lily from AT&T, and there's a kid, and she goes like, we're going to give everybody a sucker, and she gives a kid a sucker, and then she goes, and I'm going to give you a sucker too, and she gives the brother a bigger sucker. And what does she say? She goes, that's not fair, right? Well, she got a sucker, right? I mean, so on the one hand, okay, so point is that fairness is in the eye of the beholder, right? And so whatever. Okay, so that's distributive justice. Everybody should have the same thing. And I gave a silly example, but there's examples that have to do with gender and race and other things in our country. There's retributive or corrective justice, which is punishment. Like if you do the crime, you got to do the time, that sort of thing. And making sure that the punishment fits the crime. Now this happens. So this is really where the just culture comes in, is under retributive or corrective justice, because a lot of times when things happen in the medical setting, an individual is looked at as like, oh, that was them, right? And so they did it, so that person needs to be punished. And we're going to talk about one of those cases, and we'll talk about it in the context of just culture. Then there's compensatory justice, and that means if something was taken from you unjustly, you need to be compensated with getting back what was taken, for example, right? So anyway, those are the 3 kinds of justice, and really it's retributive, which really is the subject of the just culture. So in just culture, we talk about 3 things, and these all should be the same size font. That's my error here. That was a human error to make it a bigger font. So there's human error, which is any inadvertent action. So it's you're not doing it on purpose. You're inadvertently doing something other than what should have been done. And sometimes it was because you didn't know. I didn't know I was supposed to do that. So that's still an error. Next one is at-risk behavior, and the next one is reckless, and we're going to talk about those. So human error, a slip, a lapse, a mistake. Often it's a person who is unaware of the rule, and the outcome can be significant or insignificant, and the response is to console. I'm going to give an example in a bit. The next is at-risk behavior. So somebody knows the rule, but they say, oh, there was a special circumstance, and so I'm not going to do it, and so on. And again, the outcome can be significant or insignificant. And for that one, you counsel. And finally, there's reckless behavior. The person says, I'm not, that's a dumb rule. So let me give you an example. In our, especially intensive care nursing units, the nurses have these rules that you can't move a ventilated baby by yourself, right? Because of the possibility of an unplanned extubation. Anytime there's going to be movement, there has to be two licensed providers, whether it's RTs or nurses or docs or whatever, that are moving the baby. So we institute that rule. And so let's say there's a nurse that's been a nurse there in the neonatal ICU for 30 years. And she goes, this is BS. I've been a nurse for 30 years. I've been moving babies without a problem for a long time. And if the tube, okay, so the first situation is it's a new RT, a new nurse, and they got like 10,000 different rules on their first day, right? And this is their first day. They're supposed to be shadowing somebody or whatever, and something happens, and they, hey, go look at that baby. So they go look at the baby, and they're like, oh, I need to move the baby. And they move the baby, and there's an extubation, right? So then you talk to them like, hey, listen, supposed to be two people. You're supposed to do it like this. And she goes, I didn't know, and I'm new, and I always have to have somebody with me. And so for that person, for that error, right, whether the patient was harmed or not harmed, what you do is that you console that person, right? You say, hey, listen, I'm sure you feel horrible that this happened, but you really need to be aware that I know we gave you 10,000 rules. This one's like super important. You can't ever do this by yourself. You always have to have somebody to help you. And this is why. And you console them because they feel bad. The second one, it's someone like, oh my gosh, I know I'm supposed to have somebody second, but there's a code going on over in the other pod, and I don't have anybody to help me. And I kind of want to get this done now so I can go take care of my other babies. I'm going to do this just this once. It's a special circumstance. And they do it, right? And something bad happens or doesn't happen or whatever. So you find out that happened, and what you do is that you counsel them like, hey, look, I know you thought this was a special circumstance, but bad things happen, and you need to find another person to help you. It'll only take less than like 30 seconds. You need to find somebody else, or let the baby be there, or call a code if you think it's that serious, and you counsel them. It doesn't have to be written counseling. It doesn't have to be signed counseling necessarily if this is the first or second time. The third one is reckless behavior. And unfortunately, sometimes we see this in really experienced nurses. And they're like, I've been working for 30 years. I've done this. This is BS, blah, blah, blah. And they're like, it doesn't apply to me. I'm more experienced than that. And for that one, you say, no, it applies to everybody. And that person gets punished. And the punishment might be, counseling with a signed counseling statement. And then if this happens again, you can't work here and stuff like that. So anyway, so here's, if it's human error, you console. If it's at-risk behavior, you counsel or coach. And if it's reckless behavior, you punish. Okay, so that's, and again, it's justculture.org and so on. So this slide is, so this Allison Page is worked for Fairview Hospital, and she was giving a talk on just culture. And she was talking about different things about, she gave an example of like the MRI magnet story, right? And she gave So then she came up with this scenario. So I don't know if you know this, but just like pharmaceutical companies, there's also device companies, right? So the device companies come, they ask the surgeons, hey, please use my new device. And I think it's better than whatever device. Well, you can't just do that. You have to, it has to go through channels, it has to go through um, 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 medical review here and make sure it's compatible with other things and so on. So she posed this question. So what if a surgeon used an unapproved piece of equipment, right? And then in the OR, people found like, hey, what's that? Like, oh, I'm using this, one of the guys, blah, 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 right? So they asked, what if the surgeon did that, but the equipment resulted in no harm to the patient? So the question was, do you think the surgeon should be disciplined or would be disciplined? And if there was no harm to the patient, and 19% of the staff and 11% of the C-suite, and none of the docs and none of the nurse managers thought that anything bad would happen to the surgeon. They wouldn't be counseled, they wouldn't be coached, they wouldn't be corrected, they wouldn't be punished, nothing would happen. So, okay, so same doc, same equipment, but there was a harmful outcome. Do you think anything bad would happen to the surgeon? Now it's 30% of staff and 15% of the C-suite. And now it's like half the docs and half the nurses thought that there would be discipline if something bad happened, right? And so the question, which I will say is now a rhetorical question, and we'll get more into actual responses a bit later, is should the outcome affect the response, right? If someone's doing something against good safety practices, should the outcome affect the response? This ends up being a bit trickier than it sounds like. Okay. All right, so we're moving on to the next part, which is, okay. So y'all, I'm 100% sure you have all seen this because this should have come up like in the Dr. John's public health course at some point about safety and quality. Of the 5 people who I see, can you like blink your eyes or nod your heads? Thank you. I thank you, Chloe and Emily, for that. Yeah, you're 2 of the 4 people I can see, so you're screwed. All right. Okay. All right. So this is going to be possibly this is going to be the student participation part. Okay. Driving in this morning to give this talk, I saw a car slide into the intersection and hit another car. This didn't actually happen. I wrote this yesterday, but it could have happened, right? All right, so you take that, and now you have a fishbone diagram. And so to remember with the fishbone diagram, these like different ribs, if you will, that come off the vertebrae are going to be different domains. And so people, environment, methods, materials, and so on. So if somebody of the people who I can't see would preferably could either put into the chat or speak up and say like, what are some of the different things that you would think would be possible contributors to this event?
Icy road conditions.
Okay, so that's environment. So icy roads, good.
Not having snow tires.
Okay, so that would be more or less the materials. Again, I don't like this particular one, but so you have one for environment, one for materials, so they didn't have the right tires on. Good. Could there be any human part to it, theoretically?
There's some in the chat with reckless driving or people just not knowing how to drive in the snow.
Oh, hang on a second. I can't see the chat. Let me see. Oh, I did see it. Now I see it. Okay, thank you. Reckless driving. So, and by that, I'm sure you mean texting while driving, right? Or having your cup of coffee while driving because it's the morning. Nobody knows how to drive it. So love that one. I grew up in Wisconsin and I went to college in Texas. I totally know what you're talking about, right? Yeah, so there's a number of different things. Okay, so this is this is a different one that I just got off the web, right? So somebody lost control of their car, and so what could be the different possibilities? Flat tire, slippery road, mechanical failure, driver error, and so on, right? And so what you do is that you come up with all these different things like we did for this, and then like, okay, how do you prevent that from happening, right? And you know, I'm not sure you can if I mean, gosh, if people don't know that they should be attentive while driving, especially when there's like an ice storm, how are you going to fix that? If they don't have snow tire, I don't know. Anyway, but this is what we do when we have a patient safety event, and then it needs to undergo either a common cause analysis, where we'll ask the nurse manager or the physician lead of that area, like, hey, listen, this happened. Can you just look into it and what you think happened? Or if it's really serious, what they call a sentinel event, then we'll do a root cause analysis and we'll get everybody in the room and we'll go through this and then attack each one of these. And are there any things that we can engineer to make it safer? Okay, so boy, I need to hurry. All right. Okay, so these are, this is like a TV, like on TV or movies where it says these are based on actual events, okay? Okay, so there's a patient suffering from a right basal ganglia hemorrhagic stroke with an intraventricular hemorrhage. Okay, so kid shows up in the ICU, neurosurgery is called, neurosurgery says we need to come up and place an EVD on the left side for this right basal ganglia stroke, right? Because there's going to be probably the blood's going to be in the right lateral ventricle. And so we're going to place the EVD, external ventricular drain, on the left side of the patient's head for ICP monitoring. And so here's what the goal is, right? Left lateral ventricle, put an EVD in, and so on. After setup for the procedure, the neurosurge resident goes in there and they start drilling. In the middle of drilling, they realize they're drilling on the wrong side of the head. The attending neurosurgeons called and said, yeah, just keep going. It's fine. We can do the monitoring from the right side. And so therefore, quote unquote, there was no negative outcome to the patient. Okay. So was this a system error or was this a human error? Comments? The
I think
easy
it, I think it depends if a timeout is required by the facility or not.
I thank you. So that's, I think you phrased it perfectly, right? Because if you would have said, if somebody would have said, well, they didn't do a timeout. So the real question is like, are timeouts required? And if timeouts are required and we didn't do one, then that was a system error. Or actually, that would have been a human error. The system error was we don't require them. It turns out we do require them. It turns out that we require them, but it's not communicated to people that for every procedure that you do outside of the operating room, you have to do a timeout just like you do in the operating room. Okay, so the other things that come up here is that where was the nurse? You know, could the nurse have said, hey, listen, you're going to do a lateralized procedure. Can you X mark on the side of the head that you're going to do it? And then we need to do a timeout. We have everything. And we have an issue here because we have it's kind of ironic. In my view, we don't have a physician-led hospital. We have an administrator and nursing-led hospital. But then when it comes down to with the patient, then the physician's the captain of the ship, right? And so we have to get rid of these stupid hierarchical organizational charts and start thinking more about teamwork and the patient. Okay, so let's say there's a rule that you have to do timeout, and the nurse surgical resident knew about that rule. So what do you think this could have been categorized at? Is this human error? Was it at-risk behavior? Was it reckless? Or not enough information, or what? We're going to call that a rhetorical question. Okay, so so look at this. And so human factors, environmental factors, methods, rules, standard operating procedures, materials, and equipment, right? I don't think we have time to, I apologize. I should have spent less time at the beginning. But anyway, there could have been a number of environmental factors, right? So let's say in the PICU, the nurse who's caring for that patient had her other patient, she had a two-patient assignment. And let's say that kid was having some issues with either the ventilators or the vasoactive drips, and so she was over here with this patient, but she was kind of had her mind on the patient next door and couldn't devote all of her attention to that. Let's say that there wasn't a big sign on the wall that said, remember, all procedures must have a timeout. Here are the timeout steps. Let's say this nurse surgical resident was being called to the OR for a trauma, but he had to do this first. I mean, so there are a whole bunch of different things that could go into this. And so that's why, so this was a sentinel event. This had to be reported to a national reporting agency, the Joint Commission. And because it was a sentinel event, wrong-sided surgery, even though there was no harm, supposedly, we had to do a root cause analysis. And so we came up with different things, which hopefully will prevent it from happening again. But it did happen again, just to let you know. Okay. And so what we do is we tell people you have to fill out a safety report, right? It's not enough that people are whispering about this. Like, oh my God, did you hear so-and-so, blah, 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 right? No, you have to fill, it has to be in paper so it goes to the right people so that we could get the right people involved and have a root cause analysis and so on. And a lot of people, like when I was a young pediatrician, they were called incident reports, like, and the nurses would write up the residents like, oh, you wrote me up or whatever. It's like, no, there was a safety event, and the people need to know about it. And so, and again, it was usually the nurses writing up residents, but it's nurses writing up other nurses, and then the nurses get their feelings hurt. Like, I can't believe you wrote me up. Like, I'm not writing you up. It's not about you. It's about keeping the patient safe and having better systems. Second one, this is in the PICU, there was bed 20, bed 21. One baby was, I think, 4 months old. Another was 7 months old. They're both breastfed. Baby in 20, mom said, hey, I need some more breast milk for my baby. And the same nurse was not taking care of both babies. And so she goes to the milk room or breast milk room, and she goes, hey, I need to get, and it was night. And so during the day, there are people there that are scanning, barcoding stuff, but at night you go in there and you look, and then anyway, she brings back the milk, she puts it down. The nurse from 21 goes over, sees the breast milk there and takes it to her baby. So now the breast milk from mom in 20 is going to the baby in 21, right? So there's all these other theoretical issues, right? Could there be some pathogens? Could there be Hep C? Could it be HIV? Could be, any of these things that were given to this other baby, and so on. And so for that one, that ended up also having to do an RCA, a root cause analysis, like what were the human factors and what were the methods and the materials, like are there barcoding, and like why don't we have people there at night? Babies don't eat breast milk at night, and so on. So like, oh, we can't have a room with breast milk kept at the right temperature and stored in the right way and barcoded, and then have nobody there for 10 hours a day to do that, right? And so like, oh, well, that's expensive. Well, you know what? Too bad. So there's that. Okay, and then the last one, this affects probably you guys more than the other ones, right? Okay, so this is a based on true events. So there was a baby that came to emergency department, 14-month-old baby. Parents bring him in. He's been sick for about 6 hours and high fever and vomiting. And so they get to the emergency department about midnight. So they're doing the intake, and there had been around this time a little mini epidemic, a lot of people with vomiting, diarrhea, and stuff like that. So the person says, oh, what's going on? Like, oh, we've been throwing up, having fever. And like, any diarrhea? Like, well, not really. I mean, well, then mom, well, last time it was looser than normal last time. Like, oh, okay. So then the emergency doc writes in his notes, nausea, vomiting, diarrhea. So the electrolytes are done. You see the bicarb 17 with anion gap of 17, so mild metabolic acidosis. So that was done about 2:30 a.m. and so about 6 a.m. the new peds thing, they call peds to come down to possibly admit, and so they said, oh, you know what, we're going to get some repeat labs, and they never got a blood culture. And what they did, they just repeated the basic metabolic panel, right? The electrolytes and creatinine and such. And so here it was 4 hours later after 2 boluses, now the bicarb 16 and the anion gap's 18. And incidentally, the white blood cell count was elevated at 17,500. So the kid gets admitted to pediatrics. There's no blood culture taken. He got no medication, was continued on fluids. And on rounds the next day, the intern said, hey, listen, high fever, vomiting. I heard that's like this one, a really super scary combination. If you have vomiting and fever, it could be appendicitis, it could be pyelonephritis, it could be meningitis, it could be all these like really super scary things. Like, oh, no, he had diarrhea too. We've been seeing a lot of this. The new guidelines came out, because we're now giving both H-flu, Hib vaccine, and now we have this conjugate pneumococcal vaccine. We're not really seeing bacterial meningitis. And so you don't have to do blood cultures and give empiric ceftriaxone antibiotics anymore. And we're really being up to date. And so they did. And so then on rounds, they're going to go in the room, and there's mom sleeping, there's dad sleeping, there's the baby sleeping. Oh, they were up all night in the emergency room. Let's not wake them up. We'll come back later. Well, about 1:30 in the afternoon, the nurse goes in to assess the patient, and this baby is now having extensor posturing. Like, holy crap. Pupils are dilated. They take him to the CT. The kids increase pressure. Bottom line is the kid had strep pneumomeningitis and the kid died 3 days later. And okay, so they said, okay, so we could have done this if we had more time. And again, I apologize. Rules, human factors, and so on. So one of the things are cognitive biases, right? And so there's the anchoring bias. Okay, hey, we have a kid with dehydration and vomiting and diarrhea. Like, oh, another one of those. the kid never had diarrhea, right? But the ER doc wrote it, misinterpreted what the patient said, heard what they wanted to hear. So that was confirmation bias from the ER doc, right? Like, oh, I want to know if there's diarrhea. They said it was loose stool. I'm going to write diarrhea in there. So it gets framed to the peds admitting team that this is another one of those dehydrated kids who's going to be just fine, and so on. So, there are, I'm sure you all have seen this, right? There are like, I think now there are 53 cognitive biases, and we have to be aware of them. And so that intern, actually, who's now a pediatric oncologist, was the only person who was right. She was the only person on that team who was right. The attendings were wrong. The senior residents were wrong. Everybody was wrong except her. And you have to speak up. And sometimes you have zero power, but you got to speak up, right? Okay, so in conclusion, so we talked about the just culture, right? And this happens, you could use these principles in your life away from medicine. People use these in business around the world that have nothing to do with medicine. If there's human error, you can solve them. If it's risky behavior, you coach or counsel them. If it's reckless behavior, you punish them. And then the strategies to reduce error, there are human factors engineering, like computer pop-ups, barcode things, visual reminders like on the wall. There are error analysis tools like the safety reports that, we have had, I'd say it's rare that we've had a third-year medical student write up a patient safety report, but we have had fourth years write them up. And then we use root cause analysis and common cause analysis and other things to look at a lot of these things. Super important is safety behavior at the individual level and culture. Culture, the best definition of culture I've ever heard is it's the way we do things around here. And right now, when I first arrived here 4 years ago, is there a safety culture at this hospital? And the guy who was in charge of patient safety said, not yet. We're not there yet. And it's because really it has to be both at the individual and at the team level. And I think we're building that, and I see it in the Children's Hospital. The other thing is everyone has a voice. If you're a third-year medical student, if you're a novice nurse, if you're somewhere in the middle, speak up. Everyone has a voice. And if someone does speak up, it can't be, I'm the doctor, you're the nurse, this is what we're doing, right? It has to be listening to everybody, and we're all in this together for the safety of our patients. Okay, so I was told to end at 8:45, so I think I'm okay. If anybody has questions, you can please email me. It's mweiss@hsc.w.edu. Or you can email Dr. Brandt, who wasn't here. That'd be even better. And he'll answer all your questions. And anything else? So when you're going, I know that you guys do like evaluation of the talks. So this is the first time I'm given this. And so I would appreciate if you would say it would be better if, right? Maybe you didn't want time for discussion at the end. Maybe you thought this was just perfect. Great. If you would have thought, hey, listen, we really, I think would have benefited from more discussion about the cases at the end. Could you hurry up for the first part? Let me know that as well. Okay. Jillian, anything else I need to do?
I think Jillian left and I'm now the co-host or the host of this meeting. So I'm not really sure. I didn't get any instructions. I think you did a fine job. And as far as what to tell you to do from here, I'm not even sure what to do from here. So I think you did okay.
Well, I'm going to leave then. It was a
Okay.
pleasure seeing you all here. And we'll see you up in the ward sometime.
Mhm.
Hey, by the way, when do you guys start? Are you the class that starts like in the next month or two?
Yes, I think you'll see us near the end of April, beginning of March.
Perfect. All right, guys, thanks.
Does anyone else know what I should do?
Good job,
Maybe
Emma.
we
Oh,
can
hi,
look at it.
Emily. I love you.
Yeah,
Do
girl,
I-
you're doing great.
Okay, so I'm just gonna stop the recording and then end the meeting.
Well, I think there's
Steven's
a-
We have
suggestion.
class at 9.
Steven's suggestion in the chat to end the meeting. So
Oh, don't end the meeting. Okay. Do we have another lecture after this though?
I thought we did.
Okay, maybe I'll just let the recording keep going. Andy, do you know what to do?
So I think we just stop the recording, but keep the meeting going. It looks like we have sports medicine with PDCI starting at 9. So I think someone should jump in and start recording at 9, but I guess if no one does, Emily, if you wouldn't mind starting the recording.
Okay.